Before returning to the chronological accounts, something that I should make clear. I mentioned earlier that Counsel to the inquiry didn't have a clear understanding of ARMA's position on the question of targeting gay donors for plasma-rich in hepatitis antibodies. We understand that this may be because ARMA never had any such centres. And it's very difficult then to prove a negative because there are no documents to show that. So it's something that we will continue to look into, but that may be one of the explanations as to why there is no documentation, or at least no documentation that we have seen. Returning then to the autumn of 1982, I'm going to read from Dr. Everett's tragic history about the CDC's work in that time. Shumik, could we have on screen, please, CVHB 5042 and electronic page 5. And if we could highlight the third paragraph down on the left-hand side, beginning in the fall of 1982. Dr. Everett wrote this. In the fall of 1982, we identified 4 additional and 1 probable cause of AIDS in haemophilic patients, 2 of whom were children. In addition, we investigated and identified AIDS in a number of individuals who had received transfusions. Invoking donor confidentiality, some blood banks severely hampered investigations by refusing to share donor lists of persons who contributed blood given to recipients who later developed AIDS. They feared we would unduly alarm or embarrass donors with sexual questions, thereby discouraging donations. Without linking an AIDS patient's donation to the recipient of a blood component, it was impossible to show transmission. Also, transfused patients often receive transfusions for other underlying illnesses, i.e. cancer surgery, conditions that were possible sources of secondary immunodeficiency. As these cases accumulated, the author routinely provided briefings to the blood industry, FDA panels, and National Institute of Health conferences of blood banking experts, who seemed only to request more patients and proof without yielding on recommendations for changes in blood policy. Frustration and impatience grew at the CDC. I pause there to note, sir, that the primary subject of that frustration of the CDC at this time was blood banks, not necessarily the fractionators, although Dr. Everett does refer to the briefings that he gave to the blood industry more generally, but we will see shortly how some of the fractionators responded. In October 1982, the National Haemophilia Foundation resolved that no plasma should be sourced from gay men, intravenous drug users, or people from Haiti. The response of the pharmaceutical companies to that recommendation is something that we will look at in due course. The recommendation was made in October 1982, paragraph 44 of a written presentation. Relating things again to what was going on in the United Kingdom at that time, it's relevant to note that it was around then that Dr. Krask produced his initial report on AIDS. And in the covering letter that accompanied that report, he said that he had spoken to somebody he described as the project leader of the team looking into the epidemiology of the disease at the CDC, which is a reference probably either to Dr. Everett or Dr. Curran. The next meeting that I will draw your attention to, sir, took place on the 3rd and 4th of December 1982, and it was a meeting of the Blood Policy Advisory Committee. And a large number of items were discussed there, among them, many of them not to do with AIDS.
On that last, what you recited, paragraph 45 in the presentation, do we know when in the autumn Dr. Everett had recalled the CDC identifying 4 additional cases and 1 probable case of AIDS? Because that would make 7 and 1 probable case, whereas Krask was talking about 5 people.
The short answer is that I don't know. We can go back and look at the MMWR reports at that time and see if we can discern that.
The reason I ask is that it may demonstrate something of the perspicacity of Dr. Krask, if indeed he had spoken at some time before September, which it would be if Dr. Everett is talking about September, for instance, in his recollection, and drawn the conclusions that he did, which he then presented in September to those who are listening.
We will look into that, sir.
Thank you. In other words, it might have been there to be seen at an earlier stage than September.
We will we'll conduct some further studies on that.
Thanks.
Perhaps, so as we're on the topic, perhaps I can read just from paragraph 45 of the written presentation, a section from what Dr. Krask was saying in the autumn. I think that this is from his covering letter rather than the report. What he said, and I quote, is this: "The hypothesis at present being used to explain the acquisition of these cases is that 1 or 2 patients in the incubation period of a disease donated plasma, which has since been used to prepare factor 8 or 9 concentrates. All the haemophiliacs who have had the disease have had severe coagulation defects requiring regular treatment with factor 8. The likelihood is, therefore, that other cases will be identified amongst severe haemophiliacs, though probably at a low prevalence." So that is what Dr. Krask was writing in his covering letter. Moving on then to the meeting of the Blood Policy Advisory Committee on the 3rd and the 4th of December 1982. As I say, it discussed a range of topics, many not connected with AIDS or matters of relevance to this inquiry. But some of the things that they did discuss were methods for decreasing the infectivity of factor 8 and factor 9 concentrates in respect of hepatitis B, that it was noted at the meeting that that might also be of some interest because of the occurrence of AIDS in some patients with haemophilia. They also discussed the risk groups for hepatitis B in donors, including intravenous drug users and gay men. And they also discussed a study showing lower T4, T8 cell ratios in patients using factor concentrates when compared to those using cryoprecipitate. And it was noted that similar changes have been found in patients with AIDS. At that meeting, Dr. Everett reported on the CDC investigations, and he said that the epidemic was growing at an almost exponential rate, doubling every 6 months. He expressed a concern that transfusion cases, and I quote him, may follow the same increasing pattern seen with haemophilia patients. So going back to the point that you raised earlier, Dr. Everett is clearly drawing attention to the fact that this is a matter that might affect patients receiving whole blood transfusions as well as blood products. He told the meeting that 8 people with haemophilia had been reported with AIDS, only 3 of whom were still alive. 5 transfusion cases had been reported, including a child who had received a transfusion at birth. I take that to be a reference to the San Francisco infant case, which we will come on to shortly. A case of some importance because it provided in what Dr. Evett describes as an unequivocal transfusion case. That's a word that he uses in his tragic history. So it's a way of demonstrating that his hypothesis that the transmissible agent is passed through blood, which had been questioned by many of the blood banking industry, he saw the case of the San Francisco infant as being an unequivocal transfusion case. Dr. Evett also commented on the CDC's studies on the incubation period of AIDS. And he looked at 35 cases where there had been person-to-person transmission. And in those cases, the incubation period he described as being about 4 to 7 months with a prodrome before diagnosis of about the same period. The epidemiological pattern seems to be similar to that of hepatitis B. Now, I'm afraid I'm not able to discern precisely what Dr. Evett meant about the 4 to 7 months, whether he's saying that it's 4 to 7 months without anything, and then 4 to 7 months with some symptoms before what was termed at the time full-blown AIDS developed, or whether or not it's a single 4 to 7 month period. This is a paragraph 48 of...
Well, if it's an incubation period, then presumably it's before full-blown AIDS, but it may be a difference between the first symptoms, recognizable as symptoms of the AIDS syndrome developing, and a period before that, after infection. In other words, the prodromal period, infected but not symptomatic, followed by a period symptomatic but not yet full-blown AIDS, followed by full-blown AIDS.
That is my reading of it. I think that's the least strained reading of the quotation.
Well,
so that would suggest 4 to 7 months before the prodromal period and then 4 to 7 months afterwards to AIDS.
Unless there's a better reading, I think that's what I'd take from it. The only concern that I have is it may be informed by a bit of retrospectivity, knowing that indeed AIDS turned out to have a very lengthy incubation period, including the difference between the symptomatic and asymptomatic.
I think that quotation is actually taken from the contemporaneous minutes rather than from Dr. Evett's tragic history. So that is what he was telling the Blood Products Advisory Committee at the time.
Yes.
So it would seem to be free of that element of retrospectivity. But as we know, further evidence comes to light about how long the incubation period is.
Yes.
It's also relevant to note that the cohort from which the CDC were drawing this information were people who had received person-to-person transmission of AIDS, rather than people who had received it through blood and blood products. The Blood Products Advisory Committee discussed some steps intended to reduce the risk of infection, including relying on cryoprecipitate and viral inactivation techniques, surrogate testing, and excluding high-risk donors. The meeting concluded, and I quote, "There was a sense of urgency because of the continuing spread of AIDS and because of its long incubation time," which goes back to the debate that we've just been having. However, the committee did not recommend any immediate changes in biological regulations or regulatory activities at that time. Again, it is relevant to note the distinction between action being taken on a voluntary basis and action which is being mandated by changes to regulations and regulatory activities. On the 9th of December 1982, so 5 and 6 days after that meeting, the National Haemophilia Foundation informed its members of 4 new cases of AIDS among people with haemophilia and stated, and I quote, that while there is insufficient data to directly link the spread of AIDS to concentrates, there is an increased concern that AIDS may be transmitted through blood products. Interestingly, the NHF, as of the 9th of December 1982, also advised, and I quote, patients and parents should be aware of the potential risks. That's 9th of December 1982. On the same day, Dr. Riddell of Highland sent a letter to the NHF responding to its recommendations about excluding high-risk donors. In the letter, Dr. Riddell said, first, that Highland had consistently sought to exclude all intravenous drug users by checking forearms for needle marks. Second, he said that the company had, and I quote, within the past several months, made a commitment to withhold plasma obtained through targeted recruitment of gay donors, and that is a phrase that we looked at, and a letter that we looked at in September and October. The third point that Highland made was that in terms of seeking to determine the sexuality of donors, there were going to be difficulties involved in how you identify those donors. And he indicated in the letter that the company would rely instead on donor education and donor self-exclusion. We'll come on to see how Highland did that in the months that followed. He did say, however, that donors would be asked directly about whether they had been residents in or visitors to Haiti. And Dr. Riddell also referred the NHF to the difficulties that the plasma company, that the fractionation companies had in respect of plasma that they obtained from whole blood donations, recovered plasma. And again, that was something that we looked at in September and October, but we will come back to it in the months that follow. On the following day, the 10th of December 1982, an informal meeting took place between representatives of the FDA and the fractionators. And this had been convened at the request of Dr. Donoghue. We've got a memorandum of it by Dr. Stephen Ajala of Qatar. Many of the memorandums that we're going to look at come from Dr. Ajala, who made records of these meetings. And if we could bring it up on screen, please, Shumik. It's CGRA 40425. We can see at the top the date is the 13th of December 1982, so reporting back 3 days later on the meeting that was held on the 10th. The distribution list is a number of people from within Qatar. If we could start from the first paragraph, we'll work our way down this page. Dr. Donoghue asked for an informal meeting with the 4 blood product manufacturers following the PMA-FDA Liaison Committee meeting on Friday to explore possible actions to minimise the risk of AIDS. Although the transmission of AIDS via blood products, and specifically anti-haemophilic factor, has not been conclusively demonstrated, there is some evidence that a possibility does exist. Dr. Donoghue wanted to know what we manufacturers could do immediately to minimise the risk of potential exposure. You can have the next paragraph, please. Donoghue specifically asked if we could simply exclude high-risk plasma taken from areas such as New York, San Francisco, and Hollywood from AHF production. Mike Riddell, Highland, responded that he felt a more meaningful effort would be to attempt to educate the high-risk populations, homosexuals, Haitians, and drug users, and have them voluntarily exclude themselves from the plasmapheresis programs. Not everyone was convinced that a voluntary programme would be completely successful, but it would be a first step. It was recommended that any education programme be coordinated between the manufacturers. Riddell made it clear that they intended to specifically ask their donors if they are high risk, i.e. homosexuals or drug users. He maintained that public health risks overrode any concerns with discrimination. The consensus was that the education programme be formulated by a professional firm experienced in this kind of presentation. I pause there, sir, to say that what Dr. Riddell appears to be telling this meeting is slightly firmer than the information that he gave in the letter to the NHF. It seems that by this stage, Highland were considering or intending to implement a policy where donors were asked directly whether or not they were gay. Male donors were asked if they were gay.
There are marginal notes.
Yes, sir. I have struggled to decipher these, and I don't know who made them. As we can see in the bottom right-hand corner of this document, we can see it's an exhibit from litigation. So we can't even be sure that these notes were made by somebody within Qatar. I'm afraid we simply don't.
Do we know from which side of the litigation the document comes?
I don't, I'm afraid. It will have been disclosed, to adopt the terminology from this jurisdiction. It will have been disclosed in the litigation, which is why it became public.
But it doesn't look as though it's a litigation note, given the very last, the third of those entries, which is a reference to John Henk, isn't it? And John
Yes,
Henk needing to do something.
This will be a problem
At Qatar.
at Qatar.
John Henk will need to look at the percentage
Yes.
and costs.
So that would certainly suggest that that it's well, I think it's overwhelmingly likely that means that the marginalia was made at the time. I suppose it's theoretical that Mr. Hink might have been asked about that in the later litigation.
I think that's the working assumption.
Yes.
If so, then probably is this do you think a Qatar document or a Qatar annotation?
I would have thought so. The memorandum is circulated within Qatar, and certainly that note would seem to suggest that it's somebody within Qatar identifying either for themselves or for others.
And in case it matters, the marginal notes, the first is fairly clear, I think, to educate the high risk is good. What about the second?
I think it says this makes no sense. The
Homosexual
yes,
and drug user who sells plasma has no concern for others.
yes,
Yes, and this may be, the working assumption is it's an internal Qatar document.
yes.
Yes. Thank you.
Returning to the third paragraph down. Donahue then asked if we were willing to exclude plasma collected at prisons because of a homosexual link and because it constituted only 2% of collected plasma. The other manufacturers had no problem with this suggestion, but it was pointed out that this was the source of our hyperimmunized donors. Donahue then suggested that we exclude this plasma from any AHF production. It is my opinion that they will remain relatively non-negotiable on this point. It was indicated that there has been no cases of AIDS reported from prison, and Donahue responded that this was because of the etiology of the syndrome and insufficient time had transpired. I pause there to note, sir, as we've just discussed, this is a Qatar document. So when referring to how the other manufacturers had no issue with this. We can see in this document and others that it was a source of concern for Qatar. The final item of discussion related to recovered plasma, that is, plasma taken from whole blood donations. Donoghue pointed out that we would have distinctly less leverage over any voluntary reduction of high-risk donors in recovered plasma. He said that he felt we should consider very carefully if we should accept any recovered plasma collected from high-risk populations. He indicated the Irwin Blood Bank specifically. That is the Irwin Memorial Blood Bank in San Francisco. Going over onto the following page, it's a record of a brief discussion about fraction 5, and then if we could expand the first paragraph, please, Shumik. I quote, I have the impression, so this is the second sentence in, I have the impression that while the agency is concerned about the question of AIDS, they are not going to overreact to the situation. Concerns have been expressed about the safety of paid donors versus voluntary sources, and there are those who are championing the return to single donor cryo. I think the Bureau will take a more studied and scientific approach until sufficient information is available. That's where we will leave that document, sir. We could take it down, please, Shumik. Relevant to note that the CDC were not present at that meeting. It was a meeting between the FDA, specifically Dr. Donoghue, and the fractionators. On the same day that that meeting took place, the 10th of December, the CDC published in MMWR the report relating to the San Francisco infant, a 20-month-old child infected with AIDS. The blood transfusion had taken place at birth, and the incubation period was identified to be 18 months. The same report indicated that 3 people with haemophilia, whose cases had been reported in July, had all died. In his tragic history, Dr. Everett says this about specifically about the San Francisco case, but more generally about the point reached by the 10th of December. We, that's a reference to he and his colleagues at the CDC, we were now convinced that in spite of the absence of an identified agent, the pattern of the epidemiological evidence was sufficient to implicate a blood-borne disease. This evidence could no longer be ignored. In our opinion, urgent changes in blood policy were needed to reduce the risk. And that is his view as of the 10th of December, 1982. Turning to the response of one pharmaceutical company to the situation then pertaining. The company is Alpha. On the 15th of December 1982, Alpha's executive committee met for what was described as an AIDS meeting. And there, the committee decided on a number of steps. In essence, they put in place a new screening process. Patients were to be given information leaflets. Sorry, not patients, donors, forgive me, were to be given information leaflets. The donors would be encouraged to self-exclude if they were in any of the 3 identified risk groups. And male donors would be asked directly if they had had sex with another man, and if they answered yes, then they would be excluded. This new process was to be implemented in Alpha's own centres and in centres with whom it had contracted. So these were some of the independent plasmapheresis centres that provided plasma to Alpha. Alpha would also encourage whole blood centres to adopt these measures. And we will see from some documents from a few months later that this caused problems for Alpha because some of those with whom they were used to dealing were not prepared to do so. And so the relationship between them broke down. Alpha was the first of the fractionators to put in place these enhanced measures, and it did so from mid-December 1982. I'm just going to take you to a couple of the documents that show what was done and how it was phrased. And if we could have on screen, please, Shumik, CGRA 40627. This is the covering note from Dave Guri at Alpha, and it refers to a series of urgent communications on AIDS. They are a background memo to be sent to centre personnel, a memo to be Xeroxed, that's photocopied, and given to donors, and third, a memo to be given to AIDS deferred donors. If we could now go, please, to page 3. This is the second of those documents. I should say that the first of them, the background memo, is summarised from paragraphs 58 onwards of the written presentation. But I'm going to take you to the document that was given to donors. And it says, and I quote, "Dear donor, recently the medical community has noted the occurrence of a very serious disease known as acquired immune deficiency syndrome, AIDS. The Centres for Disease Control have documented an increasing number of cases of this disease across the country. As the name indicates, the disease seems to disrupt the patient's immune system, that is, their ability to fight off disease. Though very little is known about the disease or about its cause, this disease has been fatal and there is no known treatment. It appears that the disease occurs more frequently in certain groups of people, which include male homosexuals, Haitians, and drug abusers. In past years, you have helped us help others through your plasma donations. We are now faced with a situation in which only you can help us ensure a safe product to those whose lives depend on it. Because of our shared goal of producing a continuing safe supply of plasma products for use worldwide, Alpha has committed its resources to reducing the possibility that this disease might be transmitted through our products. We are now asking for your commitment also. Until the cause of this disease is determined, we are asking that people who are part of any of the following groups do not donate: Haitians, drug abusers, male homosexuals. People who are part of any of the above groups may be eligible for a special plasma programme. If you think you may be eligible, please discuss it with our medical receptionists. The special plasma programme, so was a system that Alpha put in place whereby plasma from those groups was segregated and could be used for other purposes other than the fractionation of factor concentrates. Other documents, thank you, Shumik, we can take that down. Other documents, which I won't take you to, so make it clear that in addition to providing the donor with that document, a new protocol was put in place such that the medical receptionist at any any Alpha centre would say directly to a male donor, have you ever had sexual contact with a man? And if the answer was yes, then they would be deferred from donating other than for the special plasma process. So we can see that the terminology used in that question combined with that in the document is very clear. There's no confusion about promiscuous male homosexuals as occurred in some other literature around the time. It is a straight question: have you ever had sexual contact with a man? We will see that other fractionators didn't pose the question directly of the donor, and there are, of course, arguments as to why different approaches might be more effective. A similar letter to the one a similar note to the background note was sent to plasmapheresis centres, and they were instructed that plasma obtained after the 26th of December 1982 from donors who had not been screened in the way that Alpha required them to be screened should not be sent to Alpha. They concluded their letter to their contracting centres with the following words, quotes, "While we recognise the potential for the rejection of long-term donors, we strongly believe that the loss of these donors is more than offset by the protection of our patients." Alpha's measures were introduced unilaterally. They were not part of an industry-wide approach. It was a decision that Alpha took on its own. They went beyond the measures that many voluntary and commercial blood banks were willing to put in place, and we'll see that in the documents that follow. Alpha would later report that 308 homosexual donors had been excluded from donating in the first 3 weeks of implementation, and that an even larger number had voluntarily excluded themselves. Alpha's assessment by the summer of 1983 was that in that first 6 months or so, 800 potential donors had voluntarily disqualified themselves from the pool. You may feel, sir, that it is significant that so many donors from high-risk groups could be excluded so quickly with a relatively simple measure. The company provided regular newsletters, and the one that was published in winter 1982 set out these new arrangements and quoted the medical director, Dr. Clyde Macaulay, as saying this, quotes, "So long as there is any question about the involvement of blood products, Alpha is taking all possible steps to reduce the potential risk for the haemophiliac receiving our factor 8 and 9 concentrates." It is, sir, relevant to note that those steps were prospective. Returning to the minutes of the Alpha Executive Committee on the 15th of December 1982, as well as putting in place this new scheme, that meeting also considered what to be done with products that had been produced using 3 units of plasma that had been obtained from what was described as, and I quote, the AIDS donor. It's not clear from the minutes how many lots were affected, but reference is made to one lot in particular, which comprised 2,841 vials and had been shipped in April and August 1982. The minutes record that the situation was going to be reported to the FDA and that the company, and I quote, would wait for the Bureau of Biologics' opinion on what should be done. We haven't, as yet, sir, been able to trace through all of the steps as to what happened to those products, and what the decision of the FDA was on it. The same meeting also included a discussion on the possibility of a reversion to cryoprecipitate as an alternative to the use of factor concentrates. The calculations are set out at paragraph 70 of the written presentation. In short, the committee concluded that within a year, the average patient who had severe haemophilia would be exposed to 700 donations, even with a reversion to cryoprecipitate. And a patient using 20% of that 70,000 unit average would be exposed to 140 donations a year by using cryoprecipitate. The meeting concluded, and I quote, "The use of cryo may do nothing to solve the incidence of AIDS related to AHF transfusion." Also recorded, and I quote, "Risk would be approaching that of pooled anti-haemophilic factor." The minutes don't record the discussion and the reasons as to why that conclusion was reached. There is some discussion of the costs of switching to cryoprecipitate. It was estimated that it would cost an additional $1 per unit because of labour costs. So the estimate was of 7 million donations per year, so that would mean an additional cost of $7 million in terms of labour alone. There was also an estimate of $20 to $30 million in respect of equipment and shipping costs for 7 million units. And there would be, it was said, additional costs which were not set out or calculated for shipping at minus 20 degrees Celsius. That was an internal discussion within the Qatar, within the Alpha organisation. On the 21st of December 1982, the NHF made recommendations on the treatment of people with haemophilia in light of the risk of AIDS. This is quoted at paragraph 73 of the written presentation. The organisation said that there was no conclusive evidence that the use of cryoprecipitate or fresh frozen plasma would reduce the risk of AIDS, but it recommended that patients who had not yet used concentrates should not begin to do so unless there was an overriding medical indication for so doing. And that group included children, those under 4, people who had been newly diagnosed with haemophilia, and those with mild haemophilia. All other patients were advised to continue using concentrates. That was the 21st of December 1982, and there was a slight tweak to the guidance in January 1983, where physicians were also advised to use desmopressin for patients with mild or moderate haemophilia. In January 1983 as well, there was a recommendation that the advantages and disadvantages of postponing elective surgery be considered. We've reached the end of 1982, and it's perhaps helpful just to give a very brief summary. By the end of 1982, pharmaceutical companies and other relevant bodies were aware of the potential risk of transmission of AIDS through blood products and blood transfusions, though there was no consensus about the etiology of the disease or the nature and the extent of the risk. That lack of consensus was evident between government agencies as well as between those agencies and those involved in blood banking and in fractionation. In broad terms, the CDC, or at least leading figures within the CDC, were considerably more concerned about AIDS than were other participants in the debate. Some steps had been taken to seek to reduce risk. Companies had agreed voluntarily to forego future manufacture of blood products from factor concentrates from plasma obtained from donors specifically recruited because they were gay. There was a consensus amongst the fractionators about educating donors. Other measures such as avoiding plasma from prisons and from geographical areas thought to be hotspots for AIDS were were under consideration. One company, Alpha, had gone considerably further and had unilaterally introduced its new screening process. As the events in January 1983 would show, there was, however, still a gulf between the steps that the blood industry generally were willing to take at that stage and those that the leading figures within the CDC considered to be necessary. That brings us to perhaps the most prominent and controversial event in the United States in this debate in this period. And that was the meeting held on the 4th of January 1983 in Atlanta. And we have various sources for this meeting, and they're set out at paragraph 77 of the written presentation. The meeting was convened by the Assistant Secretary for Health, Dr. Edward Brandt, at the urging of the CDC. It was a public meeting, and it was widely attended, including by figures from the fractionation industry, from each of those firms. It was chaired by Dr. Jeffrey Copland, and although Dr. Copland came from the CDC, there is some evidence that he was chosen as chair because he was considered to be a neutral figure in the emerging debate. I'm going to take you, sir, to a summary of the meeting, which was contained in the Creever report, which is a helpful way of beginning our understanding of the meeting. We'll be looking at some other sources for it as well. Shumik, can we have on screen, please, KREV 601, and it's electronic pages 750, or beginning at electronic page 752. And so there is a mea culpa here. I tried to transpose the internal page numbers of the Creever report to the external, to the electronic page numbers, and to my immense frustration, I was one page out. So all references in the written report to the Creever report are one page short on the electronic version. Now, I apologise for that. As I say, a source of considerable frustration. If we could expand, please, the first full paragraph beginning a meeting. This is Mr. Justice Creever's summary, which is, my submission is a helpful one. A meeting of the advisory group was held on the 4th of January 1983. I should just note there, sir, that formally this was a meeting of something that was often described as a work group to identify opportunities for the prevention of AIDS. It was an ad hoc meeting. It wasn't a formal meeting of the Blood Products Advisory Committee. A meeting of the advisory group was held on the 4th of January 1983. More than 200 persons were present at that meeting, including the employees of the CDC, the Food and Drug Administration, and the National Institutes of Health, representatives of the blood and plasma centres, the plasma sector, the 4 large US blood product manufacturers, the gay community, and the National Haemophilia Foundation, as well as some treating physicians. At the meeting, Dr. Everett presented evidence suggesting that AIDS could be transmitted by blood. He discussed the cases of AIDS seen in haemophiliacs, described the case of an infant in California who had received a transfusion at birth, and said that 5 unconfirmed cases of transfusion-associated AIDS were under investigation. Several measures were suggested to reduce the risk of transmission. Dr. Donald Francis, the Assistant Director for Medical Science in the CDC's Division of Virology, advocated direct questioning of blood donors about behaviour that would have placed them at risk of contracting AIDS. He also recommended that donations be tested for the presence of antibody to the hepatitis B core antigen, in the belief that persons who have been exposed to hepatitis B would also be at greater than normal risk of contracting AIDS. Representatives of the gay community objected to his first proposal because it would be discriminatory, and representatives of the blood banks and plasma industry objected to the second, primarily because it would be too expensive. Dr. Oscar Ratnoff, a physician at Case Western Reserve University who treated haemophiliacs, recommended that haemophiliacs used cryoprecipitate instead of factor concentrates. Ultimately, the meeting endorsed none of these measures. Although the participants reached a general consensus that, quotes, it would be desirable to exclude high-risk donors to reduce the risk of AIDS transmission, there was no agreement about a method of accomplishing that goal. There was also no consensus on the question of whether AIDS was caused by a transmissible agent, on the risk of AIDS from blood donations, or on the desirability. Sorry, I've just lost my place.
About halfway down.
Thank you. Or on the desirability of introducing new methods of donor screening or testing to reduce the risk of transmission. Instead, the CDC, the Food and Drug Administration, and the National Institutes of Health were each asked to submit a set of recommendations after the meeting for the prevention of AIDS in patients with haemophilia and for other recipients of blood and blood products, so that a uniform set of recommendations might be developed. That's where we'll leave that document. Thank you, Shumik. Looking at the wider documents, we can see a little more of the debate and the nuance of the argument about surrogates testing that Mr. Justice Creever mentioned. As he said, the CDC's case was presented by Dr. Don Francis. He and his colleagues had conducted studies that, in their view, showed that 90% of known definite AIDS cases were positive for the antibody to hepatitis B core antigen. This compared to a 5% figure in the general population of voluntary donors. It's important to stress he was looking at voluntary donors there, not paid donors at plasmapheresis centres. Those figures would later be contested, and we will see some further figures as we go through the documents. But the CDC's case at the time was that if you run a surrogate test for hepatitis B core antibody, then you will there's a prospect of identifying 90% of people who may have AIDS or develop AIDS will have that antibody, and only 5% in the general population will have that antibody, at least in respect of voluntary donors. Now, his position won some support, and there were some blood centres that indicated a willingness to run programmes in which anti-HBC would be tested, and there were also some other surrogate tests.
Could I just come back to those figures?
Yes.
I just wonder if you will be showing me in due course what was recorded as to what he was saying, because 90% of known definite AIDS cases is looking at the matter retrospectively. It's after they've had
Yes.
whatever it is that caused AIDS, compared to a 5% figure in the general population of voluntary donors. So the issue, if this is saying, as it seems to be, that voluntary donors are a safer source, how does it make that out? Because you're looking at donations on the one hand and you're looking at results, consequences on the other.
I don't think it's necessarily saying comparing voluntary donors with paid donors. It's just that the voluntary donors were the cohort that the CDC drew their data from. The point that they were seeking to make, I think, from this is that if you introduce anti-HBC testing, then you can expect to lose 5% of your donors at a voluntary blood donation centre because they will test positive. So your loss is 5% of donors. The potential gain is that the test, as a surrogate test, has a good correlation with people who subsequently developed AIDS, because 90% of people in their cohort who developed AIDS were positive for anti-HBC. Now, it doesn't, as you say, necessarily tell you whether or not somebody who is in the incubation period for AIDS will... It doesn't give you any figures at all for that cohort, because that's not the group that they were using. They were using any people who had developed AIDS. But I think that the inference is that as a surrogate test, it was a one that potentially could assist in identifying and excluding high-risk donors, even though it would come as a cost of losing some donors who did not go on to develop AIDS.
Yes, I'm still, at the moment, puzzling over the exact way in which scientifically the link will be drawn. Because it might very well be the point which at the moment I'm struggling with, and it may be entirely a fault of mine, is that if you take 1 in 20 people who come along who happen to have hepatitis B, you may still end up with AIDS being created in association with hepatitis B as an output to an extent of 90%. So there has to be some way of saying, well, so I don't understand what the link precisely is, but that's I'll try and work it out.
But perhaps that's something. So I'll come back to and go back to the. I'll try to find from the various sources we've got of the meeting.
Yes.
The best and the clearest discussion. But that's something I will come back to over lunch.
Thank you.
If I may. And, it may also be that Dr. Everett's tragic history may set out clearly the parameters of that debate. What is clear from the sources is that while there was some support for this proposition, there were also objections. Those objections were, as Mr. Justice Creever said, on the grounds of cost and expense, and also on the grounds that it was going to lead to the destruction of plasma without direct evidence that that plasma was infected with AIDS. Some concerns were raised about the availability of materials for the test and about the need for additional training for staff to carry it out. According to the Cutter note of the meeting, one participant who is not named estimated the cost of introducing anti-HBC testing on all donations as being at least $100 million per year. Dr. Robert Geraghty commented that he didn't think that the test was, in his quoted words, a good marker. And he noted that the test hadn't been licensed and wouldn't be licensed that year. Now, Dr. Geraghty was the director of the hepatitis branch of the FDA's Division of Blood and Blood Products, and he is expressing skepticism about the test as well. Dr. Hink, who wrote the Cutter note, and we saw his name on the Cutter marginalia a moment ago, he summarised the debate in this way. He said, quotes, the question of cost and implementation bothered many, but not the CDC. Several objected on scientific grounds. We will come back, sir, after lunch to the terms of that debate. But looking more generally at the meeting as a whole, we can see the account given by Dr. Everett in his tragic history, which summarises how he and some of his CDC colleagues felt about what happened. We could have on screen CVHB 5042. And it's page 6. If we could start with the first paragraph on the left-hand column, please. Sorry, the paragraph above it. This is what Dr. Everett said of the meeting. Naively, We reasoned that the meeting would be routine and produce a pro forma stamp for action. That is, review the data, accept the evidence as significantly supporting the case for a blood-borne infection, and produce recommendations that high-risk groups be excluded from the donor pool and or adopt a surrogate test. For example, hepatitis B core testing or immune complex tests to exclude possible infected donors. Then cites for different attendees at the meeting. If we could move to the next paragraph, please. Unfortunately, 4th of January 1983 became possibly the most discouraging and frustrating day of the epidemic for CDC staff. Rather than a rational discussion of the data, the meeting quickly became a forum to advance individual agendas and turf protection. In the presence of, and perhaps in reaction to, news reporters and TV cameras, each group voiced essentially the same sceptical reasoning they had at earlier meetings in July 1982. On this occasion, some were less polite, sometimes attacking CDC data as inadequate and overstated. The particularly vocal blood bank organisations still strongly adhered to the philosophy that transfusions were a life-saving procedure. Some adverse reactions were acceptable to save a life. A rare disorder that affected only 8 haemophilia patients and 1 transfusion patient should not force a change in blood policy. Calls were to, quotes, show us the agent, subject it to Koch's postulates. The attendees regarded the data as only anecdotal evidence without merit. 2 views emerged. To us, the attendees' reaction seemed to be those of a group approaching an idealized science problem in an abstract world. To the audience, their position was that of a group acting as careful scientists in accordance with their training. All attendees underestimated the already high disease incidence in the population because AIDS was obscured by a long, still undetermined incubation time. Dismissed as inadequate were our data on the high frequency of immune disorders affecting the haemophilia population, but were identical to those found in homosexual patients with lymphadenopathy-associated syndrome. Above all, the blood bank organisations remained unconvinced that the CDC had shown the condition to be a blood-borne disease, and some FDA officials remained unconvinced that AIDS was actually a distinct disease. Dr. Copland proposed a set of consensus recommendations at the end of the day, and all were soundly defeated. The blood banking organisations were clearly displeased with what, in truth, was the CDC's intrusion into areas considered FDA's responsibility. The attitude was reflected in a memo from a senior American Red Cross official that stated, quotes, "It has long been noted that CDC increasingly needs a major epidemic to justify its existence. In short, we cannot depend on the CDC to provide scientific, objective, unbiased leadership." Just a couple of points on that. So Koch's postulates are a series of criteria that are used to test the causative link between a suspected infective agent and a disease. And they include a criterion to identify and isolate the organism said to have caused the disease. And of course, that couldn't have been done at that time because that agent was unknown. The quotation from the American Red Cross official about the CDC is also contained in another document. And the longer quotation also refers to federal funding cuts as being relevant to the context in which the CDC were putting forward its proposals. And it referred to a perceived marketing approach by the CDC and a suspicion that AIDS probably played some positive role in CDC's successful battle to fund a new $15 million virology lab. So suspicion being expressed about the CDC's motivation. That quotation is taken from a report prepared by the Institute of Medicine, which is referred to in the written presentation. And the Institute of Medicine also placed this in the context of a previous reaction to a potential outbreak of swine flu in the United States in 1976, which led to a mass vaccination program, and indeed some deaths as a result of that vaccination program. And it was felt by some that that had been a massive overreaction at the time, and the IOM placed people's attitudes towards the CDC within that context.
So this is the IOM report of 1995?
Yes, that's right. There is a piece of video footage which I'll show after lunch so that we can tee it up properly on the machine, which has a snippet of information about Dr. Francis and an interview with Dr. Francis. And in that video, he confirms accounts that have been given many times of him slamming his fist on the table during the meeting and asking, in effect, how many AIDS cases and how many deaths those attending needed before they would act. The Qatar representative at the meeting, Dr. Hink, he produced a memorandum which also contains some further insights. Could we have, please, CGRA 40300? The memorandum was dated the 6th of January 1983, and it's an internal document. If we go to the second paragraph, please. This is Dr. Hink's impression of the meeting. Most of the meeting was devoted to presentation of information and data by individual experts. There is little question that these individuals knew their subject, but as the day wore on, it was evident that experts in other fields paid little attention to these overviews. He gives an example which I won't go through. If we could go to the next paragraph, please, Jimmy. I believe, but I'm not certain, that the objective of this CDC-sponsored workshop was to arrive at a meaningful recommendation for actions which would reduce the rapidly increasing number of AIDS disease cases being identified in the US. In particular, it appeared they directed attention to the 8 or 10 haemophiliacs with confirmed or suspected AIDS assumed to have been caused by infusions of blood products, and what should be done quickly to prevent a further increase in these numbers. However, difficulties in communication and political power struggles made progress towards these objectives difficult. The anti-discrimination position of the gays, self-serving comments of blood bankers, and lack of data to provide legitimacy to many proposals resulted in an overall stalemate. I felt a great deal of empathy for the meeting chairperson, who I felt did a good job under the circumstances. If we could turn to page 3 of this document. Dr. Hink provides various pieces of information which he attributes to contributors to the meeting, and those are set out in the written presentation. But if we go to the bottom of page 3, we can see Dr. Hink's recommendations for Qatar resulting from the meeting. So this isn't what was said at the meeting, but what Dr. Hink is advising his colleagues should do. 1. Institute a high-risk donor education voluntary exclusion program at all Qatar source plasma collection facilities. 2. Continue to exclude all plasma collected from centres dealing predominantly with homosexual populations, i.e. anti-HBS plasma collection facilities, from use in coagulation products. 3. Take no extraordinary actions, other than number 1 above, at our 2 prison centres, which supply about 3,000 litres per month. There are no data to support the emotional arguments that prison plasma collected from adequately screened prisoners is bad. To exclude such plasma from manufacture of our coagulation product would only be a sop or gratuity to the gay rights and would presage further pressure to exclude plasma collected from the Mexican border and the paid donor. 4, continue to attend further meetings of this type, accumulate and evaluate all information and data developing on AIDS, and make independent investigations on the cost, implementation, and potential effectiveness of using new Takata assay procedures. That's Dr. Hink's perspective both on the meeting and on what Qatar should do as a result. You may, sir, wish to take particular note of the position on prison donations. One further point to note from the meeting, apart from the plainly acrimonious terms in which it took place, that is the suggestion that some attendees may have considered that the CDC itself had not reached a settled view on how to proceed. Dr. Gerald Sandler of the American Red Cross told investigators from the Institute of Medicine for that 1995 report, and I quote, "Not one of Donald Francis's superiors had supported a recommendation to implement hepatitis core testing. As a result, few in attendance accepted Francis's suggestions, as they did not have the support of CDC Director William Fogg." The FDA's attitude was that more research was needed on surrogate testing before it be implemented. As I say, so the one remaining piece of evidence about that meeting that I would like to draw your attention to is the interview given by Dr. Francis, but I think it will be easier to do that after lunch so that Shumik has an opportunity to bring the relevant video up on screen.
Yes. Well, let's take a break then till 2 o'clock. 2 o'clock.